That's good.
Okay. Excellent. We don't need an introduction
No.
today, right? No need.
I think that this is our last talk here at the dental school. So I think that we don't need other introductions because we have been doing this during these 2 weeks. But I just want to thank you, Professor Glassy, for all your help and your program. This partnership for us was very important, and we are very happy that you are here with your students today. Thank you.
Like this morning, I think. Good. All right. Great. Well, good afternoon, everybody. Thank you for coming and listening again. For some of you who have heard me, or if you haven't been here, we get to meet for the first time. And I don't. This one. Yeah. Oh, it's not on. No, they can't hear. No, it's on. It's this one. But it's not on here.
Just a minute, or all ready? Everything is the same for the other time. Just a minute, I will call somebody to.
I wasn't paying attention when I turned it on. This one is this one. What's the problem with it?
There.
How many people would have been at the conference at USB, like where I gave the seminar talk? Yeah. Show. No, remember I gave a talk. I gave this was a lecture that was at a conference for special needs dentistry. Jack Joe Copy. Right. So how many people here would have been there so that they don't hear the same talk? Right. Okay. Good.
Still not working. Pode entrar. Becas. backup microphone. Yes.
A transmissão ainda tá rolando?
Ainda tá. Ah, a gente segue. Depois qualquer coisa tem que cortar.
Som.
Tá,
Qualquer coisa temos que revisar isso aqui. Sim.
Tá.
Acho que você ainda não tem o volume, se precisar baixar um pouquinho, tá?
Testando. Alô. Mais.
Não, eu tô.
Ah, tá. Alô.
É mais alto?
Alô.
Não, acho também.
Acho que não.
Tá,
Desculpa.
tá aqui, ó, volume do vídeo. Obrigado. Muito obrigado.
We're good to go? We're good?
Good.
Yep, can you hear? It's coming through? Okay.
Tá bom? Tá.
We're ready? All right, well, welcome again, thank you. And good news is I had a chance to check with Manuela, and it sounds like maybe one person in the audience here attended a very similar talk, because it was a talk I was asked to give at the name of the conference, at Jocapi, at USP, yeah, in November last year, so in the middle of my visit. So maybe there was like parts that you stopped paying attention, or you were on your phone, or you fell asleep for a minute. So, and because I was given too much time at that meeting, and there's a lot of information here, I'm going to go through much faster. Some slides I'm not going to really talk about very much because some of them are more relevant than others. And again, we have what, an hour and a half or so, but an hour and some time for some questions, and then everybody wants to get home at the end of the day. So I understand. And I know that there's some new people in the audience, so just I've been including this slide as sort of part of my introduction. This is the Longwood Medical Area in Boston, and then you can see sort of the downtown sort of financial center of Boston, and then the water, and it's the Charles River on the left. All of my experience with pediatric oncology is through sort of the affiliation between Boston Children's Hospital and the Dana-Farber Cancer Institute. I've been seeing patients at the Pediatric Oncology Clinic since I was in training, and I continue to be sort of the go-to person for anything oral medicine related. About 2 years ago, a year and a half ago or so, we actually made a formal arrangement, not just with Dana-Farber, but also with the Boston Children's Hospital. So I have in addition to my oncology clinics, I have a designated once-a-month pediatric oncology clinic at Boston Children's Hospital that I do out of the plastics and oral surgery clinic. So, and then I don't do anything pediatric oncology related, at least directly so far, but I also spend 1 day a month up at the Dartmouth-Hitchcock Medical Center, which is about 2.5, 3 hours from Boston in a much more sort of rural, remote area in New England. So I'll start with a couple of historical slides, and then everything else will be much more up to date. But some of you may be familiar with this report going back to the 1940s in the New England Journal of Medicine. This was one of the seminal papers from Sidney Farber and his group, describing at least short-term responses in pediatric patients with otherwise known to be fatal leukemia at the time. But it's important to note that within this paper, there was already recognition of the importance of oral health and oral medicine. So I'll read the section on the right, it just says on February 3rd, daily injections of 1 milligram of aminobutyrin were begun. This is sort of an agent like methotrexate. A bone marrow biopsy and aspiration revealed 85% blastforms, no megakaryocytes, and no erythropoiesis. After 10 days of regular therapy, the white cell count had fallen from 78,000 to 5,000, but severe stomatitis made cessation of therapy imperative. Within a week, without therapy, the stomatitis had healed completely, and the patient had developed a ravenous appetite, and then they go on and on. So, point being is, even in this early report, they had to stop the treatment because the patient had such bad mouth sores. And then I came across this paper actually preparing for a completely different talk maybe 2 or 3 years before that talk. And now in some of my oncology focused talks, I really like to include this one. So this was from 1957 from the Journal of the American Dental Association. And the title of this short piece is Leukemia as a Dental Problem. And it's really, really well written. And I just highlight a few things they point out. It says, the dentist should be aware of the general and oral manifestations of this disease, and therefore able to recognize or suspect it in patients coming for examination and treatment. Often the oral lesions encountered in leukemia are aggravated by local factors superimposed on tissues infiltrated with leukemia. And then finally, even though the victims of this disease face death in a matter of days, weeks, or months, it is the responsibility of the dental profession to help them however and whenever possible. It's really well written. This was somebody who was in the Army, a dentist, and published this in 1957. So it's always nice to come across these type of things. Obviously, we've made a lot of advances, but we still, if you think about the last quote, I'm still in that situation on a regular basis. So most patients hopefully do better, but we're always managing patients who are at the end of life at some point and may have oral problems. So especially for those who are interested in a little bit of history and in the oral medicine side, good paper to read. This just a summary of the most common, most frequent child and adolescent cancers. This is from the United States. These are pretty consistent anywhere you go. So ALL. Cancers in the brain and central nervous system, neuroendocrine, non-Hodgkin lymphoma. But again, the numbers start to get very small. And remember, overall, the numbers of pediatric oncology patients compared with adult oncology patients is much, much smaller. And without going into any detail here, it's just important to see that there have been significant improvements over time. So we've made a lot of advances. Some cancers much more than others, but overall survival rates have improved over time. There have also been some changes in epidemiology. I'm not an expert in the epidemiology of pediatric cancers, but some that have actually decreased over time, some that have increased. But I think this is one of the most important sort of background slides, just from an oncology standpoint, to think about a diagnosis of ALL. That going back to, for example, the first slide I showed you, these patients there's no treatment for them, right? There's no treatment, and they're going to die from their disease in probably a relatively short period of time. And you can see, going back to from the 1960s up to, in this case, through 2000, how much improvement there's been in overall survival with the same diagnosis. And it's largely been because of advances, not because of one center, one small study, but some of these larger cooperative group studies that have really moved the field forward. So much better, still not a great diagnosis, but much better diagnosis now in the modern era than much earlier. And this really does not pertain to pediatrics or pediatric oncology. This is a timeline of drug discovery, and in multiple myeloma over time. But this type of progression is also represented in other cancers and some pediatric cancers. And just to think how each of these advances has led to such remarkable differences in improvement is, as I use the word remarkable. And I came into this system somewhere in 90s into 2000s. So even in my what I would consider to be short professional career, the changes we've seen have been really pretty drastic. So I'd say that this slide, while it might be specific to multiple myeloma, and multiple myeloma may be one of the better examples where there's really been some big improvements. It's also a positive and sort of inspiring slide from the standpoint of we can anticipate this more and more. And then, of course, there have been some other really significant advances in cancer, in pediatric cancer treatment, and in particular, CAR T-cell therapy. Again, I'm not an expert in CAR T-cell therapy. I'm an oral medicine specialist, but it's obviously been a game changer, or is in the process of really changing the landscape, at least for certain diagnoses. So, why is the mouth important? Hopefully fairly obvious, but the mouth obviously can be a site of cancer. So when we think about cancer, we think about the mouth. It can be a place where it presents primarily or as a manifestation like with leukemia. It's a common site for treatment-related complications, whether acute, chronic, or even late complications years and years after treatment's completed, which becomes more and more relevant for pediatric oncology patients because presumably if they're treated effectively, they have a long time to live afterwards versus an older patient who develops cancer late in life. There's infection risk, usually around cancer therapy. Odontogenic infections are common, so the mouth just as a potential source of a contributing source of infection has potential. And finally, the mouth is important from a functional standpoint, not just oral intake and nutrition, but those are obviously critical for health. And good general health is important when somebody's being treated for a disease like cancer. So obviously, if we're going to evaluate a patient, we need as much information about them as possible. And in making a diagnosis, well, we put a lot of emphasis on medical history. We obviously have an exam also. We may need some labs. We talked about whether or not to biopsy certain cases earlier today. We need a biopsy, we need a culture, may need imaging. And ultimately, we determine what at least a working, if not confirmed diagnosis, and come up with a treatment plan. So when examining the mouth, these are all examples of encountering cancers in the mouth. So we have squamous cell carcinoma. That's actually a patient with leukemia, a pediatric patient with manifestation in the mouth at relapse. This is a patient with newly diagnosed leukemia, and that's a mucoepidermoid carcinoma, so salivary gland tumor. Just to give different examples. These are not pediatric patients, these two, but this is an angiosarcoma that's diffusely involving the entire side of the face and the parotid gland, causing significant trismus in this patient and pain. And this is a patient with multiple myeloma. You can see the classic punched out lesions in the radiograph and the plasmacytoma lesion in the mouth. Then these are two patients with metastatic tumors to the jaw or to the head and neck area. Again, these are both adult patients. Top patient is a patient with known metastatic disease, prostate cancer, and who reported that they couldn't swallow on one side, which I had not heard someone describe before. The patient was actually referred to me because they thought the patient had a tongue infection because it had that looked like it was swollen. But it's not swollen, it's just flaccid, like there's no muscle tone, because ultimately I did the exam and listened to the patient, and knowing that the patient had known metastases They evaluated for brain metastasis and indeed explained the finding. And this is a patient with very advanced breast cancer. Where you can see a very destructive metastatic lesion in the jaw, causing a lot of pain. So how do we treat cancer? How are children potentially treated for cancer? We have conventional chemotherapy. We also have targeted therapies. Some of the complications can be similar. Some of the complications can be very different. We have radiation therapy. I think most in the pediatric side of practice, and I'm not going to talk about radiation-related complications too much, but especially some of the patients with head and neck involvement with rhabdomyosarcomas, we can see some really significant long-term radiation complications. Surgery, if it's in the head and neck area, can potentially lead to complications. Immunotherapy and cellular therapies, like I just mentioned with CAR T-cell therapy, stem cell transplant. And then we have supportive care measures that are still part of the cancer therapy, like anti-resorptive therapies we talked about this morning, and ultimately palliative care and/or hospice care for end-of-life management. So this is a busy slide, and my only intent is to point to where we are with targeted therapies now. So we have really very specific treatments that in some cases can be very effective for some cancers, or at least for periods of time, in some cases very long-term, like with imatinib and the tyrosine kinase inhibitors in CML, can be curative, where you're just fixing essentially the mistake, so to speak. But many, many different pathways that can be targeted with targeted therapies. And as mentioned, imatinib was really, we could say, ground zero, for the sort of introduction of a targeted therapy and demonstrating sort of how effective having that specific molecular target can be in essentially correcting the condition. Also with immunotherapy, with the immune checkpoint inhibitors, we've also seen this curative potential, initially in melanoma, but also in a number of other agents now. And I have not seen any pediatric patients yet who have immunotherapy-related toxicities, but as I'll show you in a few slides, it is something that's starting to be used more and more in pediatric oncology. So this is a fairly up-to-date slide with a lot of different indications that are approved. These are all adult cancer, or at least primarily cancers encountered in adults listed here. These are US approvals. But as noted, it was actually a lot of fun preparing for this talk last year, doing some of this reading and seeing that there's actually there's not a lot in the literature, but there's a bit about immune checkpoint therapy inhibitors in pediatrics, and I'm interested in even some papers talking about the risk of the immunotherapy-related adverse events and efficacy, and sort of that balance, with considerations that, again, some complications that could have potentially lifelong implications. You might make the decisions a little bit differently based on the age of the patient. But also the idea that, and this is the case really for any targeted therapy, in most cases there's some sort of selection. So you might do an analysis on a tumor, for example, and identify, this person has this upregulated, this mutation. It's targetable, so we're going to manage them, and ideally have a better response because you're actually enriching your treatments. And again, CAR T-cell therapy is, I think, potentially revolutionizing many areas of medicine, but like many of the newer therapies, they're also incredibly expensive, and it's a sort of balance of one big upfront cost versus other costs over a long period of time. And these patients can relapse after CAR T-cell therapy and after multiple therapies. So I've seen a number of patients where there's not really anything, and we'll talk a little bit about it, for CAR T cell therapy, there's really not any sort of oral medicine, oral toxicity noise that I'm aware of, either from clinical practice or from the literature. They receive a fairly modest conditioning regimen. It doesn't typically cause mucositis. Oral infections aren't typically a problem. Infectious complications aren't a major problem. More the complications from the CAR T cell therapy. But I've seen many patients, when I say many, not many, but plenty of patients who, after failing CAR T cell therapy, end up being treated with an allogeneic stem cell transplant, and seeing those patients for various complications. I think, again, there's the conditioning with CAR T cell therapy induces some risk of infection, but we've never been asked to clear a patient because of high risk concerns during CAR T cell therapy. And I haven't seen that recommended anywhere as a standard of care. Stem cell transplantation, another cellular therapy, a number of malignant and non-malignant indications. When it comes to pediatrics, of course, ALL is an indication. Some other diagnoses that they may develop less frequently, but there's also a role for allogeneic stem cell transplant in some of the non-malignant conditions that like thalassemia, sickle cell noted here, patients with Fanconi anemia who ultimately develop bone marrow failure. Dyskeratosis congenita patients also develop aplastic anemia, SCID or severe combined immune deficiency, and one of these other sort of weird, less common inborn errors of metabolism. This list also includes indications for autologous transplant, which I'm not really going to talk about today. Graft-versus-host disease, a major complication of allogeneic stem cell transplant, and a complication that can be a bit of a double-edged sword, in that we know that relapse is actually less common when patients develop graft-versus-host disease, but graft-versus-host disease in itself can be fatal. So, and it's very common, as we'll talk about in a few minutes, to see graft-versus-host disease manifestations in the mouth. There's a nice paper from a colleague who's in Washington, D.C. now. I'm sorry, who's in Washington, D.C. With a paper talking about management of chronic graft-versus-host disease in children, so looking at sort of all the different pediatric considerations. Some of them are just practical considerations, because ultimately the disease is really no different in adults versus children. And I've been treating, again, the number of children we see is much less because the volume of transplant is much less on the pediatric side. But it's a really nice aspect of how and where I trained and now where I work, because I've been seeing pediatric patients since the beginning of my residency training. I just throw this out there. I'm not aware that that bisphosphonates or anti-resorptive therapies like bisphosphonates and denosumab are being used in any regular situation within pediatric oncology, but I can imagine that there are situations, and I know there's other potential indications within pediatrics where anti-resorptive therapies are being used. So just to be aware that at least on the adult side, this could be a really significant source, potential cause of oral complications with the jaw necrosis. And then I also just point out, I mentioned palliative care, hospice care, but this is a really nice paper that talks about the role of palliative care within the context of pediatric oncology and pediatric stem cell transplant. And I guess, for any of you who are interested, I think you can probably tell I am, and sort of not just the science, not even just sort of my aspect of what I'm doing medically, and not even just the broader medical context, but also sort of a little bit of the human side. There's some really interesting concepts in this paper. So. So that's my attempt to kind of do a brushstroke of pediatric oncology, what we sort of should be aware of, the different treatments, some of the potential sort of complications broadly from the treatments. I can't go through this slide in detail today for this lecture. Some of these are more relevant, some of them are less relevant. But for example, dental skeletal abnormalities noted there, all the way over on the right. That's very specific and unique to pediatric oncology. So for all the potential complications that can develop, that's only going to affect children, and generally children who are very young at the time at which they've been treated. So in particular with traditional or sort of conventional chemotherapy, cyclic chemotherapy or combination chemotherapy regimens, chemotherapy-induced neutropenia, of course, other complications hematologically are common, but neutropenia is a major complication. To be fair, you can develop a chemotherapy-induced neutropenia from some targeted therapies also, so it's not that specific. But just to be aware that in this setting, how profound the neutropenia is, but also how long the patient is neutropenic for, will significantly increase the risk. And in this setting, it's not uncommon that we see oral infections present, and or some degree of just breakdown of the oral tissue. These are the prophylaxis guidelines for oncology from the Infectious Disease Society of America. Not to go through in any detail, but just especially in the higher risk hematology oncology patients, like acute leukemia and allotransplant, you can see that we have guidelines for actual prophylaxis, antimicrobial, antifungal, and antiviral therapies. And then for those of you who were at my talk earlier, I apologize for seeing this. You saw this slide earlier as well. But this is sort of the accumulated evidence, as best as I can find, that really supports the oral cavity as being the potential source for strep viridans bacteria in cancer patients. And you can see with some of these evidence bullets that some of this work has been demonstrated specifically in pediatrics. So, and it's really a lot of this data that has really put the emphasis behind the importance of dental screening before cancer therapies. So these are all infections in patients who are profoundly neutropenic or functionally neutropenic, either odontogenic infections or periodontal infections. When we talk about dental screening, we have sort of basic principles by which we can evaluate the oral cavity, make an assessment of certain teeth. I include a really obvious radiograph here because it almost doesn't matter who the audience is. I think any physician who's had a little bit of training or just understands what teeth should look like, you can see that there's some teeth in that picture that are in really poor condition and are, at least to me, obviously potential sources for infection. There are published guidelines, and someone was telling me about some Brazilian pediatric guidelines that have been published or put forth recently. One of you were telling me maybe last night? No? Somebody was telling me about this. But otherwise, there are these nice, I think, well put together guidelines from the American Academy of Pediatric Dentistry. And they talk about the role of the dentist prior to transplant, the role of the dentist during transplant, the role of the dentist in oral health after transplant, and some guidelines with some sort of at least proposed cutoffs for absolute neutrophil count and platelet count as far as how and when certain interventions may be necessary. We talk about loose primary teeth should be allowed to exfoliate naturally. So patients don't typically need to have a bunch of teeth extracted before they're cared. This is also a really nice reference that goes through those same sort of stages of pre, during, and post, but sort of talks about the role and the relationship between the primary oncology team and the primary specialty oral health team. And this is a paper basically demonstrating, looking at cases and controls and following oral health during transplant. And basically what they were able to find was there was really nothing different between baseline and at the end from an oral health standpoint, but just because of the clinical situation, neutropenia, other complicating factors, perhaps not being able to take as good care of the teeth, that the oral health status with respect to dental and gingival health significantly worse during the middle of the treatment period. And I just threw this slide in because I think it's an interesting study, and this study looked at using xylitol, like wipes, for maintaining oral hygiene in the oral cavity, but specifically with the primary endpoint of looking at a reduction in bloodstream infections. This with a colleagues. This is a colleague in Cincinnati, in Ohio. And they got funding based on this study to do a larger multi-center study. That's a collaboration with Boston Children's Hospital, so I'm part of that group, and the Children's Hospital in Denver. So more to come on this. I have no idea what it will show, but we're just starting to enroll subjects on a very similar protocol. So we have a donogenic infection risk, risk of HSV recrudescence, something we see in adults and children, can be very painful. And obviously in most cases we have very effective treatments. But important to know that these lesions can present quite differently than we would see otherwise in a normal healthy population in oncology patients, especially inside the mouth and affecting both keratinized and non-keratinized sites. As you can see here, at least one of these is a pediatric patient, the one in the upper right. That was a patient actually who I was seeing, I think, 4 or 5 months after transplant, and we had just a really, really bad recrudescence. Oral candidiasis, also common infection in the oral cavity, related to a number of factors, but can present with these sort of classic white changes, but also can present with the red or erythematous changes, which sometimes are not so obvious on clinical exam. And a little bit of data on how and why we might select one agent versus another. So we know that fluconazole at least can be used effectively and safely in children, and we also know that it tends to be more reliably effective than topical agent, nystatin. Salivary gland hypofunction, also a significant complication of cancer therapy. Not as common in children because of, again, depending on what type of cancer they're being treated for, but in particular, chronic graft-versus-host disease can have significant effects on the salivary glands, and I've had pediatric patients who've had pretty significant problems, not just with dry mouth, but also with really rampant dental caries. I've had a few patients, not a lot, but some of the patients actually included in a report for pediatric patients. And we have ways to potentially manage, but prevention, good oral hygiene, application of fluoride, both at home and professionally, can all help in reducing the risk of dental caries. And then we have a number of topical over-the-counter agents. We have prescription agents. I've never I'm not sure if that's true, but I don't think I've prescribed prescription sialidone therapy in a pediatric patient. Not that I wouldn't potentially, but I just don't think there's been really a good indication. Whereas I use it all the time in adult patients. These are all patients with very dry mouths. These are not pediatric patients, as you can tell, presumably. But whether it's just really thick saliva, no saliva, or dental caries, candidiasis. This environment is what creates all this. This was a 12, 13-year-old post-allo transplant patient, ALL diagnosis, who you can see over a very short period of time. If you follow the dental development, you can see that it hasn't been that long. I think this is only about a year or so. Really, really significant decline in dental status, requiring multiple extractions with essentially perfect teeth before transplant. Again, not something that we use routinely in children, so I'm not going to go through this in detail, but silent therapy can work very well. And as far as I know, there would be no specific contraindications to using in children. Mucositis can be a really painful complication, quite common in the setting of stem cell transplantation, both auto and myeloablative allo transplant. Also in just high-dose chemotherapy. So I know that the oral medicine stomatology group here does a lot of work in the hospital, helping to prevent and manage oral mucositis using photobiomodulation, which is noted at the bottom there. So it's nice to know there's all that collaboration among the different groups, but it's a tough condition. Sometimes we can do better controlling symptoms. Other times we really can't control it so well. And there's a number of ways that we potentially can manage, but at the end of the day, if it gets bad, patients will oftentimes require pain medication, diet modification, and basically just kind of waiting things out. But we do have some evidence-based interventions in certain settings. Colifermin could be considered. Photobiomodulation, we know, is used, especially here in Brazil and a few other countries, quite extensively. I think we'll see that change happening sooner or later in most of the rest of the world. Cryotherapy is simply using ice chips. Very, very limited indications where cryotherapy is used. But can be used actually potentially in some pediatric oncology settings. This is the condition, really non-specific ulceration. I'm actually showing some cases of both in the upper, these are patients who have just received chemotherapy, and the lower, they're patients who were treated with chemoradiotherapy. And we actually have guidelines specifically for pediatric oncology. This is based on other guidelines and evidence-based, because most of this is not specific to children, so it sort of takes into account pediatric considerations in coming up with these guidelines. But the same treatments mentioned there, and in particular, I would say cryotherapy and photobiomodulation, have sort of the highest level of recommendation. This I'm really just putting up here to mention. Some of these agents are maybe used in the setting of pediatrics, but in most of these agents, at least at this point right now, are primarily being used in adult cancers. But some of these targeted therapies have really specific and unique toxicities that present specifically in the mouth. Sometimes we can see, like with the mTOR inhibitors, also EGF inhibitors. Sometimes we can't really see at all. It's more like we think to be something more neuropathic. And then with the immune checkpoint inhibitors, again, I'm hearing a little bit about this on the pediatric side. I'm not sure if and when we're going to see more patients potentially being treated, but these patients have the potential to develop also very significant oral toxicities or oral IRAEs, as they're referred to. I'm going to skip through. These are what the ulcers with the mTOR inhibitors can look like. There are a number of other agents, probably related to similar pathways. So you sort of enter the pathway at one point or another, but ultimately the downstream toxicity can be similar. We've seen with PI3K inhibitors, VEGF inhibitors, MEK inhibitors, all with aphthous-like ulceration. I would say some much more aphthous-like than others, but really not any more specific than that. So some example, MEK inhibitors, there's no obvious erythematous halo like you would expect with a typical aphthous ulcer. These ulcers with MEK inhibitors are much larger than typical aphthous ulcers, but they're also small. They're also fairly limited compared with some of the mucositis we see with the conventional chemotherapy agents. This was a patient with a couple of patients with very severe ulcers related to PI3K inhibition. And then with the tyrosine kinase inhibitors, and in particular sunitinib, where most of the reports have come from, but we've seen this with some of the others like sorafenib and cabozantinib and some newer generation agents. We don't really see anything. And I don't want to say don't really, because I've had a few patients where there are some lesions that they've developed, but in most cases we don't see anything, and it sort of acts, behaves, and responds like a dysesthesia, like Barton-Mouse syndrome, or something similar to that. I don't want to say just like it. And we have really no evidence base for how we manage these cases right now. With the IRAEs, we can see lichen planus-like inflammation. We can see erythema multiforme-like inflammation. We can see the salivary glands be affected. And I just note rarely in the setting of somebody who's had an allo transplant and then they're subjected to immunotherapy, you can see either activation or reactivation of graft-versus-host disease. And these patients are treated, as you'd expect, with primarily immunosuppressive and immunomodulating agents, sometimes locally, sometimes systemically. For any of you who are interested, I'm not going to spend much time because, again, these agents aren't even really being used in pediatrics on a regular basis now. But our detailed report of patients with oral mucosal toxicity also showing some treatments and outcomes. This is a patient with more erythema multiforme-like presentation, both in the mouth and skin. And at least one case that we've seen of bullous pemphigoid with oral involvement. I mentioned salivary gland involvement as well. There's been some really nice work trying to sort of better characterize and understand sort of how this is similar and or different to other immune-mediated salivary gland disorders. But a dry mouth is a dry mouth. Like I showed you with some other images, what you see here isn't dental caries, but actually it's erosion of the teeth because of presumably because of the pH of the microenvironment, and just causing basically like a dissolution of the enamel. And came across again this paper in preparing for the talk last year. So specific considerations in children's and adolescents and young adults who might be treated with immunotherapies. Chronic graft-versus-host disease. We're going to have a whole separate talk about this for any of you who are interested. I don't know if it's going to be on YouTube. No, so not on YouTube. But you can find probably some other talk about graft-versus-host disease on YouTube. But common complication, as I talked about earlier, and it's really a multi-system disease. But interestingly, the mouth can oftentimes be sort of the first and even the last area of involvement, and sometimes one of the most significant from the standpoint of like driver of symptoms and morbidity. And we know that it has a huge impact on quality of life. The mouth, very similar to like what we just saw with immunotherapy, lichen planus-like inflammation, salivary gland hyperfunction, or Sjogren's syndrome-like effect, and not so frequently, but we can see a sclerodermatous-like complication affecting either outside the mouth, the face, or inside the mouth from fibrosis. And that can be a really significant complication when the whole body is affected. It's rare that it's just the mouth that's going to be affected, unless it's some localized fibrosis in the oral mucosa. But it can be a really debilitating condition. And these patients, oftentimes, other areas will respond very well, but the mouth will not, so it really requires some direct attention.
This is an example of acute graft-versus disease, which, as you can see, just a really intense, severe condition. Fortunately, not very common where we see oral involvement of acute graft-versus disease. So most of when we talk about graft-versus disease, we're talking about chronic form, and it has this, again, lichen-planus-like appearance. You can see diffuse involvement with white reticulation, erythema, ulcerations, lip involvement. We have pretty good evidence base for using various topical steroids, topical tacrolimus, in managing patients. And I just point out here that in this paper, which came out of the National Institutes of Health Consensus Conference, there's specifically pediatric considerations for different treatments in the mouth. Risk of cancer after transplant, if you remember, one of the cases I showed, I think really early on, was a pediatric oncology patient who developed a secondary oral malignancy, oral squamous cell carcinoma. Unfortunately, the risk, as far as we know, just continues to increase with time, which sort of makes sense because even for me, who I hope don't have any significant risk factors, every year I live, my risk for cancer goes up. So, but for the mouth, it's very, very high and much higher than for other areas where secondary cancers can develop. This one in the lower right is this pediatric patient. So I started seeing when she was about 7 years old, 7, 8 years old, just after transplant, and unfortunately at 13 developed a really aggressive squamous cell carcinoma that she succumbed to. And it's just different examples of how squamous cell carcinoma can present in the mouth. There's nothing specific about these where you would say, oh, this must have arisen in a patient who had chronic graft-versus disease. These are all precancerous changes in patients, so I'm obviously looking for something like this and will biopsy, but when I see patients with these lesions, they need biopsy also, and probably some sort of definitive treatment for the lesion. When we talk about pediatrics, we have some additional cancer risk just because of the bone marrow failure syndromes, like phenylketonuria, dyskeratosis, and genda. Trismus and fibrosis is not a really common complication that I encounter in pediatrics, but it's something that I do. So this is a chronic graft-versus-host disease patient. They have full body sclerodermatous changes, but also affecting the outside and inside the mouth. We talked about patients with rhabdomyosarcoma. I've had some of these patients from radiation-related complications and limited opening. But fortunately, it's not that common in the pediatric side, and management is very challenging. This is obviously an adult patient, but this is a patient who's had radiation, has very limited opening, has bilateral areas of jaw osteonecrosis, osteolabial necrosis. It can be challenging for the patient, challenging for the provider. I mentioned this being very unique to pediatric oncology patients. So there have been a number of studies demonstrating these changes. This was a large study in which there were siblings, sort of like matched siblings, who otherwise presumably had similar home exposures, whatever it might be, but didn't have cancer. And you can see, increased risk of basically either malformed or missing teeth, some defects in the actual tooth structure, and looking at some of the potential risk factors associated. This was a study that looked specifically at transplant and also looking specifically at regimens, conditioned regimens that included or did not include total body radiation. And they had different time points, so children who were less than 3, 3 to 5, and greater than 5, and ultimately found that the age negatively correlated with both agenesis, so missing teeth, or microdontia, so smaller than normal. This one, I'm going to skip this one too. It just drives the point home that more sort of data in this paper. Osteonecrosis of the jaw, I just want to throw it out there because, again, I've never seen a pediatric oncology patient with jaw osteonecrosis. but I'm sure at some point I will, I assume some situation will arise where I could encounter. So again, especially for everyone who doesn't think about oral medicine, oral oncology, just to get a sense of all the different types of complications that a cancer patient could encounter, this is an important one, and one I think very impactful. Risk factors include radiation therapy to the head and neck, and medications, primarily anti-resorptive therapies that have a direct effect on bone, but also anti-angiogenic agents, like the ones that are primarily targeting anti-VEGF. And you can see some exposed bone, radiographic changes. I won't go through this in detail, but anyone who's interested, the American Association of Oral and Maxillofacial Surgeons, their sort of position paper on medication osteonecrosis. This table is from 2014. There's a more updated manuscript now. You can just Google and download it. Obviously, you have access here. Last thing I'll talk about, I think the last thing I want to talk about is neuropathic symptoms. I've had very few pediatric patients that I primarily manage for pain. I don't think I have any pediatric oncology patients that I've managed for neuropathic pain. But I managed a number of adult oncology patients for neuropathic pain. I managed neuropathic pain in my sort of normal oral medicine clinic as well. And I just like to highlight here because it's such an interesting condition and it's really under-recognized. But it's not uncommon in head and neck cancer patients or patients who have had, let's just say, treatment in the head and neck area to develop chronic pain, have poorly controlled chronic pain. And etiology is really multifactorial. I have patients that have just had surgery, part of your tongue cut, and afterwards it's like a constant permanent stinging pain on that side. Osteonecrosis of the jaw, as I talked about this morning, can lead to neuropathic pain. Chemotherapy, can cause neuropathy, and occasionally we'll see neuropathies in the mouth. And targeted therapies also, some like I talked about, are associated with some neuropathic symptoms. And we treat, if it's bad enough, bothersome enough, we can treat usually quite effectively with a number of different medications. Taste changes, taste and smell changes have been studied and reported, and all I'll say is that for the most part, they're short term. So during treatment, maybe for a period after treatment, a pediatric oncology patient may have some change in taste or smell, but in most cases it's going to recover back to normal. And then this is a nice sort of overview paper. This comes from the Children's Oncology Group, or COG, in the United States, talking about oral and dental late effects, good evidence base, all the things we've been talking about, and potential treatments. And then this other paper, also from the Children's Oncology Group, late effects, surveillance recommendations among survivors of childhood stem cell transplantation, and some specific dental recommendations for transplant survivors. And then these are from what used to be American Society of Transplant, Blood and Marrow Transplant, and now the American Society for Transplant and Cellular Therapy, ASTCT. The long-term follow-up guidelines, or at least recommendations, related to both the oral cavity but also secondary cancers. So we covered a lot of ground, and like I said, for anyone who was at the lecture last year, I went through some of these slides in more detail because I was given way too much time for that lecture. But I'm glad to know that if I kind of gloss through, we can actually do this in 56 minutes or so, 55 minutes. So in summary, I'd say pediatric oncology outcomes have improved over time. I would certainly anticipate that there will be more and more new advances, increase in survivorship, and potentially more clinical situations that we will be encountering. Oral complications overall in oncology are common. We talked about there's some fairly basic approaches to assessing a patient's risk, like what's the likelihood that this or this or this might happen in this patient and why, ways to prevent, and also ways to manage. There are pediatric specific considerations and guidelines out there, both for treatment, prevention of certain complications, but also long-term health follow-up guidelines. And what I tried to point out from the beginning, especially going back to the paper from 1948, is that oral health is integral to the multidisciplinary team. You guys already do it very well here, but anywhere we can work together, especially with respect to oral health related considerations, we can get better outcomes. And I know I showed this earlier during the lunchtime talk, but most people will not have a lunchtime talk. But it's amazing what telemedicine, Zoom has allowed us to do. So this is through our electronic medical record system, health record system. I have a virtual visit scheduled, and the father's driving with the child in the back seat in one car. The mother's driving back from a work conference out of state in another car, and I'm in my office, and we're all talking and having a clinical visit about the son. So, pretty amazing. I'll stop there. I'm happy to answer questions, and thank you for being a great audience and taking the time.
Questions?
Loose and lights.
Loose. Questions? Doubts? Let me check here.
And if you have a question, we'll pass the microphone so that the people who are on or are going to watch Zoom in the future on YouTube can hear. Any questions? Any? No?
I think that everybody's tired.
I think so too. It's a long day, I know. And it's my third lecture of the day. So.
Third lecture in one day, so.
All right, what's for dinner tonight? Jantar. What's for Jantar? I'll let the professor close out the session.
Okay. So, once again, Nat, thank you so much for another very nice and special lecture. As all the other lectures that we have from you these 2 weeks, all of them full of very good appointments, very good papers that we can follow and we can read with more details. But I would like to thank you so much for everything that you brought to us during these 2 weeks. I know that we have discussion tomorrow, but I think that here and with our audience in YouTube, it was our last moment together. For me, it was very special. I think that for the whole team here at dental school was very special, your presence here. And the best point of all this interaction is that we will be together for a long time, doing a lot of work and also having great moments, because I think that life is this. It's not only science, it's building relationship, is being we are here to develop new connections. So I really thank you for this.
But we will advance the science with our multi-center trials.
For sure. And all the things that you that is possible to develop in science with our groups here in Brazil, please feel free to manifest and tell us. We can sit with our colleagues, our medical colleagues, our dental colleagues, and try to organize something in a multi-center way. I know that you have very good connections with different hospitals around the world, but here in Brazil,
Connections also.
yes, Camargo, SES, Benas.
How did we get connected?
Yeah.
Fabio.
Yes, we have a good friend, and I have to thank Fabio for this opportunity, because Fabio mentioned that we can work together. So thank you so much.
Thank you, everybody.
Again, thank you, bless you, for being part of this process. I think that was very important to have all the programs that were involved, and you since the beginning jumping the idea, and it was very good to have you and your students with us today. Thank you so much.
Boa noite.